Bismillah ar-Rahman ar-Rahim. Our lecture today, it is a continue my subject growth and development. Now, growth of the nose. Growth of the nasal bone is complete at about age of the 10 years. Growth thereafter is only of the nasal cartilage and the soft tissue, both of which undergo a considerable adolescent spurt. The result is that the nose become much more prominent at adolescent, especially in boys. The lips are framed by the nose above and chin below, both of which become more prominent with the adolescent and post-adolescent growth, while the lips do not. So the relative prominence of the lips decrease. This can become an important point in determining how much lip support should be provided by the teeth at the time orthodontic treatment typically end in a late adolescent. In this figure, we can see the nasal bone, how you can grow up until about the age 10. But after the age 10, growth of the nose is largely in a cartilaginous and a soft tissue portions. Concerning the maxillary sinus, as the sinus has the volume of a small piece at birth, the eruptions of deciduous teeth will modify its volume and it increase in size with the eruptions of the first molar, about 8 years. It has a pyramidal form that will lengthen after the eruptions of the canine and the last molar. Now, a development of the palate. The palate begin to develop early in the 6th week, but the process is not completed until the 12th week. The most critical period during the palatal development is the end of the 6th week to the beginning of the 9th week. The entire palate develop from the following. First, the primary palate or premaxilla. It is a triangular shaped part of the palate anterior to the incisive foramen. Its origin is the deep portion of the intermaxillary segment, which arises from the fusion of the two medial nasal prominences. Second, the secondary palate gives rise to the hard palate and the soft palate posterior to the incisive foramen. Its arise from paired lateral palatine shelves of the maxilla. These shelves are oriented in a superior inferior plane with the tongue interposed. Later, they become elongated and the tongue becomes smaller and move inferiorly. This allows the shelves to orient horizontally, to approach one another, and to fuse into a midline. Later, of these lateral palatine shelves fuse with the primary palate and nasal septum. Cleft palate result if the lateral palatal shelves fail to fuse with each other, with the nasal septum or with the primary palate. This figure represents the both primary and secondary palatal growth. Now, cleft lip and palate. The most common craniofacial anomaly caused by failure of the fusion between certain embryological processes during a facial morphogenesis, failure of fusion between the medial and lateral nasal and the maxillary process result in a cleft of the lip and or the alveolar process. Failure of the fusion between the lateral palatine process result in the cleft of the palate. The etiology of the cleft lip and palate is thought to B. Multifactorial. Genetic is implicated in 20 to 30 of the patients. Environmental factors that have been shown in the experimental animals to result in clefting include nutritional deficiencies, radiation, several drugs, hypoxia, viruses, and vitamin excess or deficiencies. In case of complete or bilateral clefts of the lip, alveolus, and palate, the maxillary arch typically is collapsed in the transverse direction, especially in the area of the cleft. The maxillary permanent lateral incisor at the line of the cleft may be congenitally missing or malformed and may atypically shaped, and supernumerary teeth may be present in the area of the cleft. This figure represents different types of the clefts, including the lips and palatal cleft. Now, classification. Cleft can be complete or incomplete, and it can occur unilaterally or bilaterally. A useful classification divides the anatomy into primary and secondary palate. An individual thus may have clefts of the primary palate, the secondary palate, or both. Now, cleft lip is classified either unilateral or bilateral, and it could be minor cleft of the lip, small notch in the upper lip, or an increase in severity to a complete cleft of the upper lip, or increase in severity to a complete cleft of the upper lip, or continue to reach the nostrils or to the internal angle of the eye. Mostly unilateral, sometimes the cleft lip may include cleft of the alveolar ridge. Now, cleft palate. The fusion of the palatal components that form the palate usually start from the anterior aspects and continue posteriorly, so that the cleft palate could happen at any site through this process of fusion. Cleft palate can be classified according to its severity as follows. We have class 1, cleft of the soft palate uvulae; class 2, cleft of the secondary palate, median palatine cleft; class 3, complete unilateral cleft palate; and class 4, complete bilateral cleft palate. And this figure represents the different types of the classifications of the cleft palate. Now, the growth rotation. Growth rotation are most obvious and have their greatest impacts on the mandible, particularly in the vertical direction, while their effects on the maxilla are small. Mandibular growth rotation results from the interplay of the growth of the numbers of the structure, which determine the ratio of the posterior to the anterior facial height. The posterior facial height is affected by the following. First, the direction of the mandibular growth at the condyles, and the vertical growth at the sphenooccipital synchondroses. The anterior facial height is affected by the eruption of the teeth and the vertical growth of the soft tissue, including the masticatory musculatures. Now, types of the growth rotation. The rotation of the either jaw is considered as forwards or anterior and given negative signs if there is more growth posterior than anteriorly. Counterclockwise rotation, bringing the chin forwards and upward tendency to the skeletal deep bite. B, we have a rotation is backward or posterior and given a positive direction if it's lengthened anterior facial dimensions more than the posterior one, bringing the chin downward and backward. Clockwise rotation, tendency to the skeletal open bite. C, we have average rotation, a mild forward rotation which produce a well-balanced facial appearance. We can see in the figure A and B. In figure A, we have a counterclockwise rotations. We have increasing the posterior facial height, increasing posterior facial height, decreasing the anterior facial height, and lead to the skeletal deep bite. While in figure B, we have increasing in the anterior facial height and decreasing the posterior facial height, and there is a posterior rotations of the mandible, and we have to height to tend to skeletal open bite. And thank you for your attention.